N-methyl-D receptor antagonist. The side effects are noted, but I want you to focus on Aricept, because our patient was put on Aricept that started this discussion. Nausea, vomiting, a lot of GI stuff. However, there's some other stuff that's associated with Aricept. A lot of things like hypotension, bradycardia, rhythm disturbances, heart block. So, GI upset's the most common. However, syncope, bradycardia, atrial fibrillation, abnormal ECG, headache, confusion, bad dreams, hallucinations, somnolence, crying, agitation, confusion, personality disorder, acetylcholine type side effects. So the drug can cut in two ways, either good or bad, and it's hard to know what's in the balance until you do it, until you give that drug, okay? I think I'm going to kind of talk about, this is a study from the New England Journal that looked at very advanced Alzheimer's. It looked at a fairly large number of patients who had all kinds of medical conditions in addition to an overwhelming Alzheimer's disease. And here's what was found. In patients who have had long-standing Alzheimer's disease, who have advanced and who are fairly along in their course, if they develop eating problems, dysphagia, if they develop febrile episodes for reasons that were unclear, if they develop pneumonia, whether aspiration or any other kind, they had a very significant death rate in the purple. Or I'm sorry, yeah, I guess that's a deep purple. If you look at them individually, eating problems are harbingers of terrible outcomes to come. Now, febrile episodes aren't so good, pneumonia's not so good, but eating problems, dysphagia, etc., are high predictors of decreased survival over a 6 to 12-month period. It's an important study. What it also showed is this: the percentage of people that are developing these untoward conditions towards the end of their life. And that's what these bars will show, whether it's agitation, aspiration, pressure ulcers, pain, or dyspnea. As those increase in patients with advanced dementia, especially those that we see in the nursing home, their time is coming near. Okay? Now, I know this is hard to read, so I'll just kind of summarize it for you. They looked at the DPOA, the families, those that are decision makers relative to the patients who are developing these untoward events. And here's what was found. If you educate the family of what's going to happen in that patient once they begin to develop these side effects, what their chances of survival are over the next 6 to 12 months. People who understood both of those concepts better imposed less burdensome interventions on their loved one. If they only understood one concept or the other, they imposed a little more, oh, send Mabel to the ER. And if they didn't understand or believe either, Mabel went to the ER plenty. So in those nursing home patients that you may be seeing and dealing with, as these complications occur, it's incumbent upon you and your staff and the social workers, what have you, to help educate the families about what's to come. Very important. Otherwise, Mabel's going to get a lot of burdensome interventions that aren't going to help her one iota, going to cost everybody a lot of money, and create a lot of suffering, pain, psychological turmoil, both in the patient, the family, and the staff, the physicians, everybody. So the communications, the better people can understand what's going to happen in that situation, the greater the chance of not imposing such burdensome interventions, of using things like palliative care, which is really highly underused in this population, probably many elderly populations, even to the point of using hospice. And Lottie, there was a question earlier by one of the people in the audience to me before I started that kind of thinks about what we talked at the end of yesterday's session in terms of the relationships of when do you know someone with advanced dementia is in their last 6 months of life. And I suggested that maybe some of this information I've just shown you might be the harbinger of that situation. And maybe that's something we can talk about. So the conclusions were pneumonia, febrile episodes, and eating problems are frequent complications in patients with advanced dementia. These complications are associated with high 6-month mortality rates. Distressing symptoms and burdensome interventions are also common among such patients. And patients with healthcare proxies who have an understanding of the prognosis and clinical course of advanced dementia are likely to receive less aggressive and burdensome care near the end of life. Now, I wanted to skip over to what we heard yesterday in terms of depression and kind of put a little different face or a little more of a face on it from a clinical perspective. A major depressive episode, according to the DSM-4 guidelines, would include either a depressed mood and/or anhedonia, loss of pleasure or interest in what had been pleasurable and interesting before. You can see appetite change, weight loss. You can see insomnia, hypersomnia, psychomotor agitation, retardation, loss of energy, feelings of worthlessness, guilt, difficulties with concentration or decision-making, and recurrent thoughts of death or suicide. Elements of the diagnosis, and this is going to be key. In order to make the diagnosis of a major depressive episode, requires absolutely either number 1 or number 2 that was listed. So either anhedonia, which is loss of pleasure, or a depressed mood. They must be present along with at least 3 of the other criteria. So 1 or 2 majors, and 3 lesser criteria. These symptoms must be occurring every day for most of the day for the last 2 weeks or more. And the symptoms must be causing significant distress or impaired functioning and not due to a direct physiological cause. Now, how many times have you seen somebody make that diagnosis of major depression with all those elements present? Not that often. In truth, when you look at what happens in the geriatric population, although you may see that, much more commonly, you are going to see clinically what we call subsyndromal depression. Symptoms of depression are an elderly individual that do not meet the threshold requirements for a clinical diagnosis of MDD or unipolar depression. The prevalence of this type of depression is substantial, approaches 15% of the elder population, with increasing rates depending upon the setting, whether it's the office, the nursing home, or the psychiatrist's office. Subsyndromal states are not inconsequential. They're associated with increased use of healthcare services, excess disability, poor health outcomes, and higher mortality rates. So you don't have to get the whole 9 yards. You may only see a little bit of it in that patient, and that patient's still at significant risk, and that's really the message. The DSM-4 criteria require that the depressive symptoms are not a direct effect of an underlying medical condition or the medicines used to treat it. Unfortunately, frequently there's significant overlap between symptoms of depression and physical illness. Older patients are generally more preoccupied with somatic symptoms and less frequently report depressed mood and guilt preoccupations. Worry about death and dying from an underlying illness may look like symptoms of anhedonia. So depression can have a very interesting face. You can also see what's known as psychotic depression, which should be suspected when People have irrational beliefs that focus on somatic symptoms or around fears of a serious medical condition without medical evidence to support the belief. Frequently, information from the family or caregivers is needed to determine if a clinically meaningful syndrome has developed. Psychotic depression is dangerous. It frequently requires hospitalization, frequently requires antipsychotic medications, frequently requires ECT in those areas of the country where ECT is available. This is a significant condition. And sometimes it can look very simple. And that's where it's disarming. As noted earlier, the older patients are more often preoccupied with somatic symptoms and less frequently report depressed mood and feelings of guilt. With psychotic depression, patients have sustained irrational beliefs or delusions in association with depression. And these delusions not infrequently focus on physical or medical preoccupations like the belief that one's bowels are blocked by cancer. So, you really have to pay attention to your patient, what you're hearing, because if they keep saying, you know, my arm hurts, and boy, the doctor, they worked it up, and they worked it up, and they can't find a thing, but my arm keeps hurting. It may not be the arm. It may not be the arm. And this is a patient that might need a little more professional help relative to if you're lucky enough to have geropsychiatry available to you. So pay attention. You know, there's a, for those of you that are familiar with the HMS Pinafore and Gilbert and Sullivan, the opening act, or the opening song in the second act, is a song that goes, things are seldom what they seem. Skim milk masquerades as cream. So you really need to be aware. It's important. Anyway, the dementia is very common in the elderly, increases with advancing age. The most common form is Alzheimer's. It's an insidious onset, evolves over years, and terminates in death. Its course is complicated frequently by agitated behaviors, depression, psychosis, delirium, all of which can be found in patients with Parkinson's. Medications are not curative and currently do not alter the natural history, although they may provide a modicum of symptom improvement. But in that modicum may be the difference between who you can keep at home and support and who needs to be institutionalized. So it's a really important modicum. It's hard to know who's going to respond. The high mortality rate seen in advanced dementia, especially associated with the complications noted, suggests that early palliative care consultation and evaluation might lessen burdensome interventions and improve the quality of life for the patient, as well as ease the burdens for the family. This is highly underused in the country, not just in the state of Montana. Better informed family and caregivers make better decisions. Now, I wanted to go back quickly, and I don't know how to do it except by this. We had a case. Now, let's go through this really quickly. 65-year-old man comes to your office complaining of whatever he complained of, cognitive problems. The doctor evaluates him and he puts him on Aricept. Says he's in early Alzheimer's. You know, did I give you enough evidence to make that diagnosis? No, absolutely not. Did that doctor do the right thing? No. Okay, good. You've learned something today. Great, I'm happy. So he didn't get the right diagnosis. He put him on a medicine that, as we go along in the case, creates a problem. He has Stokes-Adams attacks. You know, the guy gets sent to the cardiologist. He has Mobitz type 2 block. Any cardiologist will put a pacer in on that, and they did. But the primary care doc and the cardiologist didn't ask the question, what medicines are you on? What are their side effects? Because if they had, they would have stopped the Aricept. It was a drug you didn't need anyway. Okay? Well, he gets a permanent pacemaker. Now he comes to see guys like us, which I hope he got a benefit from it. And we kind of did the only thing geriatricians do. We sat there and listened, because we don't know what else to do. We don't dialyze, we don't operate, we don't put in pacemakers. It's really a boring life, but you sit there and you listen.